If we're going to be about to begin our program for the night, thank you all for coming. Humanity for Prisoners is the organization that is sponsoring this event tonight, and we're very, very pleased that there's so many of you here to take in this experience. One of the things that are on our agenda as an organization, among other things, is to find a way to bring hospice into the prison system here in Michigan. And it's to that intent that we're inviting you all here tonight and to engage in the various activities we'll have. In addition to that, Humanity for Prisoners is in general an advocacy group for prisoners. Doug, do you want to say anything? I'll let you talk later about Humanity for Prisoners. Doug Chapkus is to my left, your right. He's the founder of Humanity for Prisoners. I'd like to just let me first share with you how the evening is going to go. At about 7:40, there'll be a video that we're going to watch on the Angola prison system and the hospice program that they instituted in Angola. That will be about 20 minutes. After that, we're going to have a forum of folks from various perspectives to share in the context of hospice. Let me share with you who will be the forum members. We have Dr. Steve Bergman, who is present with us tonight, and he is the Regional Medical Director for Corizon. Corizon is the organization that is contracted with to provide medical care in the Michigan prisons. We also have Dr. Tom Aguirre. He is the Medical Director of Hospice of North Ottawa. We also have Dr. John Mulder. He is the Vice President of Medical Services with Faith Hospice. Also, Heidi Washington is here. She is the Charles Eagler Reception and Guidance Center in Jackson, Michigan. She's the warden there?
Yeah, I am.
All right, thank you.
Prison hospital.
Okay, good. Thank you for coming. She will also be a part of the board, or part of the forum. And then we have two women who are widows of prisoners who died in this last year within the prison. Diane Russell and also Sarah Mercer. And then, so those are the folks that will make up our forum. In addition to this, I just want to recognize also some guests that we have tonight. Mary Burgess from the Brooks Correctional Facility in Muskegon. She's the warden there. She's present with us. And Sherry Burt from the Muskegon Correctional Facility, warden there, is also present. Thank you for being here. And we also have from Citizens Alliance on Prisons and Public Spending, Barb Levine. She's the founder of that organization. Deanna Anderson is also here. She's the administrative assistant for the Citizens Alliance on Prison and Public Spending. And Natalie Holbrook is also here. She's a program director from the American Friends Service Committee. So, very good to have all of you here, as well as the rest of our guests. Why don't we begin with the Angola video?
It takes a lot out of you, but it put a lot in you.
Did a lot of wrong when I heard a lot of people out there. And when I heard about hospice, it was in my heart to join because I say this would be my way of giving back to society. Can't tell those people that I was sorry for what I did. You know, the ones that's living, you know, they wouldn't want to hear it. So instead of me talking about it, I'd rather do something about it. this is my way of doing something about it.
Who would have thought that Claude would be taking care of somebody? I mean, it's nothing for me to go in if a guy is sick to bathe him or to change his diaper if necessary. That don't mean nothing. But years ago, man, I would have never thought of that. And guys that know me know this.
When I came here to be the warden, it didn't take long to realize it, and realizing 85% of the inmates were going to die here, and you have to think about, well, what about the inmates who are in here who are suffering, and how do they die? And they go off to the hospital, and nobody really with them, no family with them, because by the time you've been here 25 or 30 years, most of your family's dead or gone. And then hospice came to mind. Why don't we have a hospice program? And I read something about hospice in the Baton Rouge paper. And so the idea just took off.
Very first time someone said to me, Warden Kane wants a hospice program at Angola. He says he wants it, and it's going to happen, so we're going to get it done. So I think at first there was a little resistance, and it was not like we don't want this, but we were mindful of where we are and who we are and who we take care of and why they're here. The principles, the main principle of prison hospice is the same as it is in hospice in the community, and that's to provide comfort and caring to a patient in the last days of terminal illness. So that's no different. There are different components of hospice, and also there are different components of a prison hospice. So what we do is we take the community hospice, and then we add those components that are necessary in a prison setting. So we have nursing, physician services, we have pastoral care and bereavement, we have volunteer services, we have social work services, and specific to prison we have classification and security.
When we began the program, we were in two separate places. The prison knew a lot about correctional issues, and we knew a lot about hospice, but we didn't have an integrated knowledge base, and that was one of the first challenges. We needed to learn each other.
Hospice is a team concept, and in the free world we don't have anybody on the team who's security, and in the prison you have to have somebody from security because they're involved in everything that goes on there. And we thought if we're going to be effective in doing prison hospice that we really need to understand that component of it.
As far as my security staff at the treatment center, at first it was hard for them too, because most of these people, hadn't been in Angola but maybe 1 or 2 years. And they go through the academy and they show them how to be a hard nose. And, if an inmate is messing up, write them up and lock them up. And when you get a program coming along like this where you got to care for somebody or actually try to do a little extra for somebody, and they look at me and say, why do we have to do all this extra stuff for this inmate? And that's when we first started getting into the program. And now it's real easy for them. I guess it's a different thing when you see somebody dying on their last leg there,
The interdisciplinary team is a team of hospice professionals. It includes the doctor, the nurse, social worker, classification, security, pastoral care, and any other staff member that has some involvement with hospice and or is interested in providing hospice care. During the IDT, we also formally admit patients. Prior to the admission process, each discipline pulls together their own assessments, so we're able to discuss what our findings are and formulate a plan of care.
Greg, we're going to just do IDT just on Danny today for time. And Richard, do you want to start the psychosocial?
There were 3 occasions where I attempted to gather psychosocial information on him. On all 3 occasions, either he was asleep or he was not lucid or clear enough to provide information. So this basically comes from Tanya's interactions with the patient and the patient's family. He's currently diagnosed with lung cancer with metastasis to the brain, and he was diagnosed on 5/98.
We expected he was going to sail down here about 2 days ago, and he didn't. But I don't think he's going to make it any longer than a week.
Has the family given any indication about how to handle his body at the time of death? Because he has not wanted to talk about that with me.
I think they're probably 98% sure that they want him to be buried here. They're not financially able at this point to absorb the cost.
Some people might get mighty tired if we run a vigil through 3 or 4 or 5 days.
Are you as far as volunteers?
Mm-hmm. You can switch the volunteers around, I expect.
Don't worry about that, because during vigil, security does allow them to be released from their jobs when they're on vigil.
The administration went to certain inmate leaders, explained the program to them, and asked them to suggest members for this first group. The idea behind that was that this program is for the inmate population, and they, better than anyone else, can guard the integrity of the program. They need this program, they know they need it, and they have a personal investment in making it work.
We were doing this type of work, we just didn't know they had a name for it. Idea came about, well, let's do a hospice program. Well, what is hospice? Oh, coming to the hospital. I said, oh, we already doing that, you know. So we pretty much, with the first group of guys, almost handpicked the guys, because we knew all the guys who were already doing this, and just went around and asked them, look, we're trying to start a program to do what you're doing now. The guy said, what's that? Visiting a patient in the hospital, sign me up.
In our death awareness training, some of the questions we ask are, what was your first experience of death? And I asked that question, and I told them to think about it, and very shortly after that, one of the inmates raised his hand and he said, well, he said, I have to tell you, he said, for some of us, our first experience with death was with the person that we murdered. We didn't avoid that in any way. It's not like we modified it, but it just gave us a different awareness, and it gave the training a different feeling.
So we need to be always mindful of the fact that these people deserve our respect, and that's all I've seen out of any of them.
The inmates absolutely embrace this program, and it's changed how they think about going to the hospital. It's changed how they think about dying in prison. It's had a profound impact all the way around.
The hospice philosophy was to make you more comfortable, you know. You're already uncomfortable in prison. You're uncomfortable with the number of years you've been down and the separation from your family, to where the people in Angola, the other inmates, become your family after, I've been down 19 years. You know, after 19, 20 years, this is more or less who your family is, you know, your closest family. You become closer to prisoners in here than you do to your own brothers and sisters in the streets, you know.
One of the things that is important to hospice is when someone dies, that we have a bereavement program in place, not only for the family who lost them, whether it's their biological family or their inmate family, but for the volunteers who sit with them.
We're going to try to look upon the mystery of life and death as our brothers experienced it and as we experienced it with them, as a reaching out for the light.
I remember the first day at the hospital over there, I was, you know, and I just told him. He didn't say anything. We just started talking about death and life, you know, and I explained a lot of things to him. I'm not quite sure what all I said, but I know there was something that happened between us. It kind of, I can't explain it. I walked in one time to come see him, and I reached over to shake his hand, and Dre just pulled my hand to him, kissed it. He woke up and he made signs. I thought he wanted me to massage his back. And so I picked him up by his neck and pulled him up so I could reach his back. And he whispered in my ear that he wanted me to hug him. While I was hugging him, he told me he loved me. Last thing I heard him say,
This program has opened some doors for men to recognize the value of friendship in a healthy manner. The program has clearly developed an experience of family among the men incarcerated here that is something I have always known as crucial if a real humanizing of this environment is to take place. These things have already happened at a very small level as a result of hospice.
Presently, there's a man who's on vigil at Angola whose family has come. One thing that hospice tries to do is to treat not just the person who's ill, but their family as well. And we consider them a unit of care. We don't consider them as we just take care of the patient, we just take care of the family. We take care of everybody. Whatever their emotional, spiritual needs are, we try to minister to that as well.
Put it on the back of the head, right here on the neck, on the neck, it stops the arm on it. And put some cold towel.
I was really surprised when we got here, and there was a guy from hospice sitting in there, and it was a lot of relief to know that he wasn't by himself. I mean, it's not family, but it's somebody there at a time when he needs somebody.
My heart was heavy, very heavy, because I had the need to see my brother, to let him know I forgive him. And that it's okay, you know, he's forgiven and he can go home in peace. And this hospice has given that to him. These guys that sit here lovingly with him and pray with him and just sit, some of them just sit hours on the side of his bed not saying a word if he doesn't want to talk, just to let him know that there's someone there.
And in a way, this hospice program has let me see from these families coming up in here how they're crying and how they're hurting over seeing their loved one in a position like that, that I put people in positions like that and in places like Patients Inn. It's not nice, you know. I have a mother, I have a family, and I wouldn't want nobody to do me, you know, what I did to other people, to have my family grieving over me like I see these families grieving over patients in here. So the hospital program has enabled me to let go of a lot of anger, animosity, and hate, you know. I was a little racist even before I got into the program, you know, even coming to prison. I don't hate, you know, it was, for me, coming from a rough neighborhood, it's always a white and a black thing. You know, because the judge gave me my time, the DA was white, the lawyer, so evidently you build barriers up. The hospital program helped me tear that down, because I can honestly say I love my patient, and he white.
For us, the inmate volunteer corps is essential. And we talked about, do we want to allow volunteers from the outside to come in, and the decision was made that we did not, and we felt like that increased the security risk to bring in people from the outside. So I think that any institution that would feel like that they could not incorporate volunteers into their program, I would hope that they would look at that very carefully, because they're a great asset.
Dealing with another inmate is just something about, you know what I'm saying? I might not tell you as a doctor, I might tell them, you know, because I feel more comfortable with them because I done lived around them. So if you never been in the situation, you never been in jail, how could you tell me about jail? You never been there. You know, how could you tell me how I feel and you never been locked up? You know, even though he might be dying, I know that I'm here, I have enough time, well, I may have to die here. So all this running through my head as an inmate. And so I want to be there for him, because I feel the pain that he feels.
The hospice program came along at a time when we ran out of space at Point Lookout 1. They made space for a new cemetery that can accommodate 2,000 people. Well, we knew right then that we had a problem, that they were making preparations for people to die here. The laws being as they are, life meaning life in Louisiana, guys are staying here so long till they're dying here. So I think hospice came along at a time to, I guess, accommodate it. you know, that if the guy's gonna die in prison, let's try to make that transition that much easier.
This hasn't always been like this. At one time, we'd come out here, drop a guy in the hole and go on. Now, as you can see, we're set up to have a full-blown funeral with all the respect and dignity that the guy's supposed to have, okay, you know, in death. And the hospice program, once it started and everybody focused in on prisoners dying, we focused on this too. As I chose, I didn't want any operations. And I'm sure other people will feel the same way. I don't want to be butchered up by doctors experimenting with my body, you know, to see if they can do anything with my liver. They can't guarantee me a cure, and they can't even give me any good percentages that they can even help me or give me any quality of life. The most that I've been told that my quality of life could be through hospice, you know, that they're going to help preserve my dignity and ease my suffering, you know.
When you go through nursing school, you're taught to save lives. And your first concept is to do everything that you've learned, everything that you can conceive to save that person's life. Well, in hospice, they've elected to just let their disease take their course and to accept death. And you as a nurse have to accept the fact that this is what they want. And you can't do any heroics or anything like that to try and make it better for them. In some cases, you're making it worse because you're prolonging their agony. This is a concept you have to accept in hospice. I was told before we started that the security would be prohibitive, but the security has not been a problem. I was told to be careful, that the inmates were manipulative and would only do things if they thought there was something in it for them. And that has proved to be untrue. Not only proved to me, but proved to the prison administration to be untrue. On a more practical side of it, you can save a lot of money with this program. And that is a concern, a practical and a legitimate concern. It doesn't make any sense to spend money on treatments that are not going to be effective. And this whole country, as well as the prison system, is going to have to come to grips with that.
In the hospice program, we are dealing with men who are coming to the end of their sentence. And I don't care how long their sentence was, even if it was life. That individual may have done some really awful things in life and impacted the lives of others in a very destructive manner through that. We recognize that. And if we're going to prepare those who are coming to the end of their sentence to be constructive citizens, then I think we also have an obligation to prepare those who are coming to the end of their sentence through death. And just as importantly, for preparing those who have been touched in some way by the life of that person for being at peace with the death of that person. And my hope would be that society can see what we're doing in hospice in no way as a coddling of men who have committed crimes, but simply as a way of preparing some human being who is coming to the end of their sentence for doing so in a way that is peaceful and open to something constructive.
Well, I feel as though now if I never get out, if something happened to me before I get out in here, that I won't have to be alone. When that day comes, I don't feel as though I'll be frightened of it. This program gonna go higher because you got guys in it that's sincere. You got guys in it that, you know, we used to think about ourselves and the heck with anybody else, you know. And I've seen the guys that used to run around Angola and want to fight and jug up, actually cry and be heartbroken over the patient. And this program, it's going to go high. It can't help but go high. You got some dedicated people behind it. No longer bound.
At this time, I'd like to invite the panel members to come on forward to the panel table.
Once again, on behalf of Humanity for Prisoners, I'd like to thank all of you for coming. I apologize for the shortness of voice, but it's the card I've been dealt tonight, so you're going to have to live with that. We'll get the sound man to turn it up a little bit. But thank you again so much for coming. Humanity for Prisoners has been considering this whole idea of hospice care for Michigan prisoners for some time, not only based on personal experience with death behind bars, but based on really some startling facts. Human Rights Watch, for example, reports that the number of senior citizens in American prisons is higher than it's ever been, and it's growing at an alarming rate. In fact, the number of prisoners 65 and older surged 94% or 94 times the rate of overall prison population in the 3 years that was prior to the study. And the people from CAPS who are here tonight will tell us that the percentage of the Michigan prison population 50 and over is approaching 20% now. Well, we're not here tonight to discuss Michigan's shameful record of keeping people in prison longer than other states, and we're not going to discuss the huge increase in cost to incarcerate the aging and the ailing, but that's probably a topic for another forum. But I simply started with that bit of information to set the stage for our discussion this evening. Last year, more than 100 Michigan prisoners died of natural causes. And unless the parole board has a dramatic change of heart, that number can only go up. It's going to happen. And it's going to go up dramatically, we think. Last year, HFP took its first steps to simply throw out the idea of hospice care in Michigan prisons. And we started by going to the top. It took almost a year, but we were finally able to bring about a meeting in Lansing of top officials from the MDOC, from the healthcare division, from prison healthcare provider Corizon, and from Hospice of Michigan. And the results were really disappointing. In fact, nothing really changed, nothing really happened. So today we're trying again, but we're trying now at the grassroots level. We wanted to show Edgar Barron's short documentary first. I guess that pales in comparison to what we're going to see with his second documentary at 9 o'clock. But I wanted to use that to get the discussion started. And we'll conclude this part of the program right at 9 sharp so that we can see the HBO special. Serving on the panel with me once again are Warden Heidi Washington, who represents MDOC Healthcare tonight, Dr. Steve Bergman representing Corizon, Dr. Tom Elguire of Hospice of North Ottawa, Dr. John Mulder of Faith Hospice, and two women whose husbands died behind bars last year, Diane Russell and Sarah Mercer. And before I ask them to speak, I just want to interject one quick note. Yesterday, Marcia and I received a call at home from Shirley Lawrence. Her husband, Jim, died at home. He had been released just 2 months ago. She's planning to take her case to court. Jim's lack of care, while in the final stages of brutal cancer, she claims was shameful. We were afraid he wouldn't get home in time. We were trying. But she was like that woman in the Bible who kept pestering the judge. She wouldn't let up on the parole board. And I think the parole board chairman just couldn't take it anymore. And the story, you can read the whole story on our HFP blog. But now to the subject at hand. And I think we should perhaps first hear from the two widows, just to get this started. Diane, could you tell us a little bit about your situation?
My husband Otto had COPD, and it was getting worse. They sent him to Dwayne Waters, and of course they don't tell you when they're transferring him in, and I only found out through inmates that he was there. Every time I would call to see how he was doing, they'd say, oh, he's doing fine. And I was not allowed to visit for, I think, 1 or 2 months. They don't allow anybody to visit. So I had no idea other than he's fine from a nurse or somebody. The last time I called, the man told me he was fine, and he said, well, we had him out for some tests. At that time, he was dying. And yet that man lied to me, and he was one of the officials at Duane Waters, and he told me my husband was okay. The next day I was in shock when the nurse called me and told me he had passed away. As far as I know, I wrote for his medical records. It took me quite a while to get them because I had to go through all the legal channels of probate and so forth. I didn't have his death certificate for almost 2 weeks after he died, so I couldn't even start the whole process. So it took me about 2 months until I found out what actually happened. And as far as I know, he was totally alone, other than a nurse coming in to see if he was breathing the last few days of his life. And that was it. He was alone. Nobody knew. I did not know. His own family is all passed away. I'm really his only family now. But I just felt how alone he was. As far as I know, he was a Christian. There was nobody in to see him. There was no chaplain service. I don't think they even asked him if he wanted to see, a chaplain or a priest or anybody. There was no record of any visit of that sort. He was alone. That was it.
Thank you. Sarah, could we hear from you too while we're talking? Are you able? Okay.
I had gone to Lakeland facility August 23rd to see Joe, and I was told he was transferred, but they wouldn't tell me where. But I knew that it was Duane Waters. That was the last place Joe could be transferred. During those 2 weeks, I was locked out of all communications. The last 2 days of his life, in fact, I had called Duane Waters over 8 times. I was hung up on. I was put to dead-end extensions. I was told somebody would call me back, and they never did. The day before I got the message that Joe had died, the nurse had told me that she had just spoken to Joe. He was tired and weak, but he would try to call me later in the afternoon. At 2:50 that morning, the next morning, I got a phone call Joe was dead. And then I got all kinds of apologies. I'm sorry, apologies don't mean anything to me at this point. And then talking of death certificates, I have 3 sets of death certificates. I still don't know the exact day that my husband passed away. Because I got a phone call one day and 2 sets of death certificates with a different date on them. So, 2 of Joe's major instances happened over the Labor Day holiday. You'll find with the Michigan Department of Corrections, if it's a weekend or a holiday weekend, you're going to be stonewalled every step of the way.
Thank you. We've got to hear from the state here as well. And Heidi, I think it's time to hear from you. Heidi is the warden of the Egler Center, but I think Duane Waters too. Is that correct, Heidi, or not?
That's correct, yes.
Okay.
Yes. I am the warden of the Charles Egler Reception and Guidance Center, which runs the intake for all prisoners coming into the Michigan Department of Corrections, and also operate the Duane Waters Health Center and the C unit and the secure units in hospitals in Lansing and Jackson is all under my administration. So I'm not going to speak to specific cases. I don't have the details of these cases. I can tell you that Duane Waters is the state's only inpatient medical facility, 152 beds, and we take care of all levels of custody in a very complex environment. We do, I believe, try very hard to work with families and to ease difficult situations. We do have 2 social workers that work on staff who I know personally communicate day in and day out with family members. I participate in interdisciplinary meetings, care conferences on the patients there, and it is a team approach. So again, I don't know what happened in these 2 cases, and I'm not going to speculate.
No, I understand that. Steve, could you respond to a little bit from what you've heard? And Dr. Steve Bergman is a regional director of Horizon. He's also a physician, and I have come to appreciate him and his opinions and his discussion. Could you respond to this a little bit, Steve?
Sure. I think, one of the things that happens in any institution, whether it's a prison or a hospital, is that we have communication problems sometimes, and that's not to be excused, but it's a reality. And I certainly want to offer my condolences to these two gals. I don't know anything about the specifics of their cases. My experience, though, after 25 years of family practice and then moving into the prison system, is that the prison system, the MDOC employs the nurses and all the support staff, and they are some of the most compassionate people that I've ever had the pleasure to work with. Not all of them, certainly, but the majority of them are. And the same is true of the physicians and mid-levels and PAs, nurse practitioners. It's not a perfect system, but I know people work very hard at it. They're certainly not there because of the money. Make a lot more money in the world than we can in prison, but they're there because of dedication.
Heidi, back to you again for a second. Is there any kind of care that is provided for people at the last stages of life in the prison system now? I mean, especially, I was thinking about this Choices program, and maybe you could explain what that is a little bit and what it does provide.
Okay, well, Choices is actually Horizon, who's our managed care provider.
Okay.
It's their version of hospice. And we do have in the state some 40-some patients enrolled in Choices. There are 2 phases to it. Phase 1, which is the time when you're diagnosed with a life-limiting disease. And then as that disease progresses, you can go into phase 2, which is at the point where it's determined you're not going to take necessarily any further life-saving measures, although to be in Choices, you do not have to sign a DNR. We do have people in Choices that still want to be a full code or some version of that. But throughout the process, much like what was shown in the video, we have interdisciplinary meetings. We do involve our chaplain. We have religious volunteers, and in the past have had a hospice volunteer come in. We don't have a hospice volunteer per se right now, but are willing to utilize one if one became available. We do things in the program with special diets, comfort foods, comfort measures. There are a number of things that we do, and I would concur that the staff are very compassionate and very caring, and I see it on a daily basis when I'm in the hospital. So that is what Choices is.
Okay. Could you follow up on that a little bit, Steve, on the Choices program?
Sure. Choices program is a kind of an offshoot of hospice. It is a voluntary program. Inmates may request to be in hospice. From a purely medical point of view, it really makes our job much easier. I recently had to go to the doctor, and I came away with a prescription, and my insurance company said, sorry, not on formulary. I had to go back to my doctor, get a different prescription, and finally on the 3rd try, I got one that was on formulary. We also have to work with a formulary. We have some additional issues with, with abuse and diversion that we don't have to deal with on the outside. But the reality is that once a patient is in the hospice program, which we call Choices, the physicians now no longer have to ask for permission to get something off formulary. They no longer have to submit a bunch of paperwork to try and get a procedure or a test done that would normally take more time and more effort. We can just go ahead and write for painkillers. We can go ahead and write for anti-anxiety agents. We can go ahead and write for whatever that patient needs. As Warden Washington pointed out, it also creates a team concept, an interdisciplinary team concept, where physicians and security, pastoral care, nursing, social workers all come together and so that everybody's on the same page for these folks.
Doug, may I make a comment? I've been hearing this. I have letters from Joe where he was denied medication. Supposedly the doctor of choices changed his meds or denied him meds, and then all of a sudden, a week or so later, he would be given his meds again. He almost died a year before he did with an esophageal varices bleed. Medical staffs turned him away, and then they ended up doing a cauterization, and he needed a second one, and the choices doctors refused that second level of the cauterization from him. So I'm disagreeing with what I'm hearing.
Diane, was your husband in the Choices program?
He was, but I don't think he understood that it was a hospice program. I did a lot of research on the internet and concluded myself that that's probably what it was. But my sister had hospice when she was dying, and she was at my home with her husband. My husband did not receive the kind of services she did under hospice. I just didn't, I don't know. I know the nurses at Duane Waters do a remarkable job. I've had experience with him being there earlier for something else. And the social workers are great. My problem really was with the administrator who lied to me and told me my husband was fine, and he had just come from a meeting that decided my husband was actively dying, but he did not tell me that. He didn't give me any warning, and I was in a state of shock when I was called the next day. I don't think that's fair to a family.
We have two physicians here who are medical directors of hospice facilities, and after you're hearing a little bit of this now, I'd really appreciate your reactions. Tom, what are your thoughts as you listen to this?
Well, I'm not in the situation that anybody is here. I know we have difficult situations anywhere that you practice. I don't know the restraints that these gentlemen are under when they're trying to administer that kind of care in a hospital, in a prison system. So I really don't know quite what to say. You have two people that are very unhappy up here, and two others that are explaining how these things can happen, and they can happen anywhere. The communication problem. I imagine there's a lot more stress when you're in a prison system. And I'm trying to walk down the middle of this and try to learn more than I can tell people. I guess when I listen to the stories of how we're going, it's nice that you have the program. The people that are involved, I'm sure, give heartfelt care. You do that when people are sick generally. I don't mean to discount what you've said. I know that you can have bad experiences. I guess I would wonder if when you have a hospice program like Choices, do you have people that are trained in hospice to administer that? Do you have people that have degrees in palliative and hospice care? I guess that would be one thing I'd be interested to know.
And regrettably, I have to admit that we probably don't have as much training as we would like to have. We certainly have people who, like in social work, and certainly physicians and nurses who have been involved with this program now for a couple of years. Are they perfect? No. Could we have more training? Probably. Yeah.
I mean, I think we can always have more training, and just to answer your question, the direct care providers, the nurses and the doctors and so on that work at Duane Waters, I can't speak to their individual backgrounds in terms of hospice care, but there is a hospice nurse who oversees the hospice program, who chairs and presides over the interdisciplinary team meetings and coordinates what is going on with the patient care and with the Choices. I'm sorry if I meant to say Choices, but the Choices program. So yes, she is a hospice nurse.
Dr. John Mulder, your thoughts?
Well, I've been involved in some aspect of hospice work for nearly 30 years, almost as long as Dr. Alguire there. And my first experience involved with prison hospice was down about a decade ago down in Nashville, Tennessee, their maximum security prison down there, in which this was shortly after the Angola experience had really become more of a public understanding, and those of us in the hospice industry were taking a look at that. I would say that most people would not ever argue with the fact that people who are dying need humane and sensitive and compassionate care. I think that's part of our humanity to really understand that that's an inherent and an important part of what we do as human beings for one another. And so the maximum security prison had someone who was dying, and they contacted our hospice to see if we could participate in that. And we were able to care for this one individual. It was logistically extraordinarily difficult, as you can imagine. The security measures, the restrictions, the ability to get medications that we typically use within the community to get those into the prison and to make those available. There's an awful lot of hoops to jump through. And what I really learned at that time was that to expect that we can provide hospice care within a prison system the way that we can in the community is just unrealistic. I think that what we see in the Angola experience is that the philosophical approach can absolutely be done within the confines of a prison system. Philosophically, when you see the compassionate care that was delivered by the inmates and how effective that is, it surprises me that every prison in the United States doesn't say, let's rally those prisoners, those who have the capacity and the personality and the style and the character that allows them to be good volunteers. I guarantee you every prison in the United States has prisoners that could serve those volunteer roles and could provide that care. In the two cases that we have up here that didn't go well, I would agree with the comment that communication is not perfect, and here it resulted in persistent pain and grief that just has not been resolved. It's very, very difficult to do that. And I would, if I had to be honest, I would say in the context of my work as a physician, there were times when we didn't communicate well with families, and we were not restricted by regulations, we were not restricted by prison bars. It just sometimes when human beings are involved, things don't go as well as we would hope that they would. And so I guess my reactions would be, I'm pleased to hear the Choices program. I think that I agree with Tom's point, is that it would not be a very long stretch to say, let's make sure that the people that are involved in both the administration and the actual practical bedside administration have additional training. And they don't even need to be certified, they don't need to be experts, but they can certainly have training in what it means to die, what it looks like to be dealing with a dying patient, the types of things that can be done with or without the restrictions of a prison environment to bring compassionate and meaningful care to their bedside, and how we effectively communicate with families about what's going on. And I think that's not outside the bounds of possibility.
You raised a very interesting point that was brought up in the first meeting that I had with Hospice of Michigan and with Joanne Sheldon, who is the administrator of the healthcare of the MDOC, and who could not be here tonight, and asked Heidi to take her place. And that was the involvement of inmates. And when that was brought up by Hospice of Michigan, Joanne Sheldon said that the MDOC had already decided that it did not want to go along with involving inmates. Do you know anything about that? Or are you aware of that decision and what that meant?
I'm not aware. I don't know when that statement was made. What I can tell you is the department has, I think, is taking a little bit of a different look lately at the utilization of inmates and some things we haven't traditionally used them for, like our prisoner observation aid program, where we now have trained prisoners to sit with other prisoners who are on one-on-one direct observation for self-injurious behavior or suicidal ideation. So,
and that's working well, isn't it?
It is working very well. So the department has changed its philosophy on that and is doing that now with positive results. We have just finished a work group looking at our aging population and breaking it down into acuity levels, and I had participated in some discussions about the potential use of prisoners to do some functions, and I think at the Lakeland facility, prisoners do assist other prisoners in some of their ADLs, activities of daily living. Now, where that discussion is going, I don't know. I haven't heard anything of late, but you know, I can tell you it has been a current topic of conversation.
Also in that meeting, I'm just thinking back on that meeting now, also in that meeting, the Hospice of Michigan offered to send training people in, perhaps starting at someplace like Coldwater, or one of the other facilities. And that met with a cool reception too. Do you think that feeling is changing as well? Do you think that MDOC might be open to more?
Well, I don't know the context. I guess I would hesitate to say, because traditionally the department is very open to volunteers and to volunteer services of all types. So I would have to check with Ms. Sheldon and see what her thought process was on that.
I think it's really important at this point, because we have about less than 30 minutes before the next video comes up, to hear from you. And we have a microphone for questions. And Dan, I'm wondering if maybe it could be replaced a little bit so people could get to it. But we would love to hear your questions. We can be talking about this all night, but many of you came with specific thoughts in mind. You at least had questions about hospice, and I would like to hear from you. Rich?
My name is Rich Reenstra. I'm from Grand Rapids. Thank you, Doug, for the meeting, and all of you. Steve, we know you from Coffee House way back in Muskegon about 40 years ago. I was, 40 years ago, also on the State Commission on Aging. I remember Ken McInnes. You remember him as the director? He came to the commission. This is a commission that's appointed by the governor, and asked the State Commission on Aging to explore the whole area of hospice. And so that wasn't a motion to have it or anything like that. It was a search for funds and so on. I would like to know where the authority is to get something rolling here. You had a meeting, you brought in interest and so forth. What is it going to take, an advocacy group of citizens, or what department would majorly be responsible to see whether this is a viable option or not? Who would answer that?
Now back to you again. All the state questions come to you.
That's okay. Well, I think that Doug is pursuing the avenue that is the appropriate avenue, which is to go through the Health Services Administrator and up that chain of command. When I get back from this panel, I will certainly make an inquiry myself and see what the thought is and where that discussion is.
Steve, any response as well to that?
Well, I think, the thing that happens so often with all of this is money. And our legislature approves the money. So I think, an advocacy group probably has to go to their elected officials and make their case known and push it. I think I agree with Heidi Washington that the appropriate place for change is through the department and the Health Systems Agency, but they still have to have the money for it. The money has to be appropriated. So I think a combined effort, one through the department and one through legislature, I think is the way to go.
We have some people here from CAPS and from the American Friends Service Committee. I'd really love to hear them.
I have a question.
Oh, okay. I didn't see you there. I'm sorry.
So, Heidi, I'm wondering if there was a place that wasn't at a level 5, and if physical terminal illness was actually part of classification, because you run a level 5 facility. Duane Waters is level 5. It's maximum. So it makes it more difficult for a family to be involved. I'm just wondering what could be done to put hospice patients, terminal patients somewhere else other than Duane Waters so that people have more access to them. And also if choices somewhere else within Corizon has contracts in other states. Is there a choices program at a lower security facility in other states and what that looks like?
Well, on the subject of choices, it's a statewide program. Everybody that's enrolled in choices, whether it's phase 1 or phase 2, is not necessarily at Duane Waters. That's first of all. And although it is true that the majority of deaths in the department do occur at Duane Waters, as far as it being a maximum security prison, it is Duane Waters is the state's only inpatient medical facility, so we have to accommodate all of our different custody levels. I have to be able to take care of a guy from Barragum Max, or from Marquette Branch Prison, or from West Shoreline, or from Cooper Street. So I have to accommodate all custody levels. I understand what you're saying, and I think that you also know through your dealings with me that I try to be as generous as I can when somebody is at the end of their life. And I do allow on-floor visits, bedside visits,
Yep. So you
regularly,
do.
all the time, as a matter of fact.
So to make your job easier, I'm asking to make your job easier.
Well then,
it's really
wonderful.
Honestly,
you.
I don't think it should be such a struggle to get bedside visits for somebody who's dying in prison. And is there any way to make it a different setting so that it would be easier?
I don't know that I would say it's a struggle per se. I understand for those trying to visit, it is a struggle. A couple of things that I can say about that. Number one, at my facility in this spring, we are embarking on a project to move our perimeter road around right now C unit, which is a step down to Duane Waters. So it's a level 1 low security housing unit that houses 120 prisoners who are not necessarily sick enough to be in Duane Waters, but they're not well enough to be in a GP unit. That is going to come within the secure perimeter of my facility. So what that means is it will be able to accommodate other levels of custody within it. So right now, perhaps, and I don't know because I don't have all of this figured out yet, but once that happens, I could possibly be using or taking some of my Duane Waters guys who are at the end of life and maybe allowing them to, like right now they can't go out there because they're doing life. You can't, right? So may be able to have an area there where they could go now in a less, in an area that it provides them some more opportunities, if you will, because it's going to be inside of the fence of Egler. So that's one thing. The second thing is that the department had a work group that I alluded to earlier that looked at the entire population, and there still are plans going forward with addressing how and where to appropriately house the sick prisoners, the prisoners who are aging, who maybe are not best suited in a GP area. And so that discussion is underway. We are, of course, limited by our existing physical plant and, of course, by finances. So we're looking at existing physical plants and other possibilities, and that is an ongoing that is current and present hot issue.
Okay. Thank you. Do you have a choices program in another state that is run in one place, in one compound, that's lower security?
Corizon has been very proactive trying to get programs in other states. They have been less successful elsewhere than they are here. I have to give some kudos to the state of Michigan for being willing to go as far as they have. It's still a program that's evolving. The addition of a hospice nurse was huge. I think there's still considerable debate among correctional healthcare professionals about whether it makes more sense to put a lot of time and effort and energy into a widespread hospice program, or maybe we should be looking more at medical paroles at the end of life. There's a lot of debate about that. and we don't have an answer to that yet. But there's a lot of discussion, and again, I just have to say that MDOC is also being proactive about end of life, but also just the aging population of otherwise healthy people in wheelchairs or whatever that just have a difficult time getting around. But it's a program that's evolving.
Thank you.
Thank you, Natalie. Yes, ma'am.
Hello, I'm Robin Anderson. I'm a nurse practitioner with hospice and palliative medicine, and I actually have visited Angola and seen their program. And what I'm hearing from you, and tell me if I'm wrong, Angola is really a gated community. They have everything in there, and so these patients that get into this program, that's where they live, their community. And I think in Michigan our situation might be a little bit different in that they go from the facility they've been in to Duane Waters when it gets towards the end of life because they're more complex. And so do you have a pool of healthy inmates to pull from to be your volunteers? I mean, that would be a question. And also the model of figuring out first from a community standpoint, what are we going to do? Are we going to support the system within if we're going to keep these people in prison, how are we then going to take care of them? And if not, the parole at end of life. But I think that has to be answered first before you can start moving on. Then now where are we going to go? How do we plan for this? Does that make sense?
It does. I think, the prison we saw in that video is very unique compared to anything we have in Michigan. We don't have any 5,000 inmate facilities on, 180,000 acres or something, where we can put that many people together and have one hospice program. That would be very, very difficult in this state. The reality is that we have to have a lot of little hospice programs spread out across the state, which makes staffing more difficult and it makes coordination more difficult. So yeah, it's a different situation.
Because
for sure.
you have to understand their program too with the inmates. If they use them as volunteers, they provide them with extensive training also. It isn't that they just pick them up and say, okay, go do this work. And that's the other thing about doing this kind of work is that it really is a specialty, and we have to acknowledge that there is special training to be able to do this work well.
On this subject, can I just say, I've been to Angola myself personally as well, and it is a very different place. There's nothing like it here. It's also it's the south, this is the north, and there's a lot of differences. But your point is good, that we don't have necessarily a big workforce at my facility. Now, we've made it work, and we have made some changes, and it's just like everything in the Department of Corrections, we adapt and we figure out how to make it work. So we have done that with the Prisoner Observation Aid program, and it has worked. So whether or not something happens in the future, but the other thing, and the other wardens can attest to this, the prisoners themselves, unlike Angola, the prisoners in the Michigan Department of Corrections want to stay at their facility where they live, where their friends are, where they've lived for years. And when they get to that point in their illness, that's what they want to do. So they do resist coming.
Right, and that makes sense. That's just like when they talked about it in Angola, that's their life. I mean, they've lived there for 20 plus years, and
Right.
So they know the people.
Right, so yeah, it is different.
Yeah, I agree.
My name is Paul Betts, and I have Lakota LLC, which is a consulting company. But the reason I'm here is I spent 6 years behind the walls at Jackson. 3 years I volunteered to do the hair and the chronic care and the age unit. At the time, this was in the late 90s. And I want to just share with you ladies the experience that you had with officers there. First thing is, of 100 officers, 80 of them are just doing their job. 10 of them are actually really good guys. And 10 of them are just heinous human beings, sorry, but they are. And they tend to gravitate to positions where they don't have inmate contact and they have public contact. That should be addressed, because that's just the nature of the way it goes. But the other thing, when we were doing the cutting hair at the hospital in there was such humanity that you wouldn't believe. They really, truly cared. And I was in 221 South on there, and the base unit was always the older people that really were not quite in the position to be in the hospital yet. Every time guys would come back from the chow hall, they would bring back extra stuff for these guys. They understood it and they truly cared. One of the problems that I see that could be addressed is the transfer situation. When someone is trained for a job, a lot of times they get transferred. There isn't that sense that they're there for a long time. This being a very unique type of a position, that it should have a longevity at a place because it's a highly specialized thing. And these are a lot of the lifers that you know that are going to be in similarly situated things could be put into one of those units over there because, honest to God, inmates care about one another. They do, especially if they've been there a while. And I'm so sorry that you had a bad experience, but for the most part, people are just doing their job there. The ones that are bad hurt it for everybody. Sorry.
Do we have any others who have questions? Go ahead, John.
Yeah, just a couple quick comments. As I think about the care, Robin's comment about it is specialized care. We do need that, and Steve's comment about hiring a hospice nurse to oversee some of these operations. I think that is so critical, and I know that the hospices I've worked in have looked at how can we bring this resource into the prison, and I'm not sure that that is the correct way to look at it, quite frankly. I like the concept better of growing the programs from the inside. I am in a minority, and at the risk of offending is not the right word, but the person that trained me in hospice and made me the person I am in hospice is sitting out there, and I don't want to. And so when I come out to say, I don't think you need a hospice to provide great hospice care, I think that, again, philosophically, you can do that. The other comment I wanted to make was about medical parole. Our hospice took care of one such patient a number of years ago. And in fact, we were contacted by Humanity for Prisoners to say, how can we provide resources and service to this gentleman who was being released, who had no family, no friends, but he was granted the medical parole. We said we would take him. And it was a powerful experience for him. It allowed for some reconciliation and some things that we had never anticipated on the front end. The real practical thing is we probably lost about $30,000 because there was zero payment source for him. And not all hospices have the capacity to do that. So if we're looking at programs for medical release, medical parole for these folks, there has to be some acknowledgement that, maybe there are some families that would say, yep, we'll bear the cost and we'll take care of that. But many of these persons will not have that kind of, so it's a funding issue whether they stay in or whether they go out. And so I think Steve's comments about how do we get either internal or legislative action to be able to acknowledge the reality of this, and I think that all of us that are in the field know that you spend $1 on hospice, you save a bunch of bucks somewhere else. So,
John, if most of these people are over 65, why don't they have Medicare? Do they not when they come out of prison? I don't know the answer to that.
No, they don't.
I didn't know that. I don't know if everybody in the audience understood that.
Or Medicaid. They don't have Medicaid.
So they're denied those, yeah.
That is correct.
Okay.
Barb Levine is here. Barb?
Hi, thanks. I just have a number of, but short, very specific questions. On the question you just raised about Medicaid, would not, under the Affordable Care Act, will that not be broadened? Would hospice care, like skilled nursing home care, be covered under the Affordable Care Act?
Well, I'm not going to make a lot of comments about the Affordable Care Act because we don't have that long. Okay.
Well, does Medicaid now cover hospice care the way it does?
Yes, Medicaid does cover hospice care, and there's nothing about the Affordable Care Act that changes the basic concepts of coverage for hospice care. That'll be intact.
So wouldn't that cover?
But at least, well, no, because when someone is released, they don't necessarily have coverage under the state's Medicaid program, at least as I understand it, and the people that we have cared for that have come out of prison don't automatically qualify or have Medicaid coverage.
Well, we do in the department have a program, and we have social workers who are dedicated to getting guys Medicaid eligible prior to leaving prison. So we are constantly working on that, and sometimes even for guys who have a parole. I'm not talking about a medical parole, I'm talking about a straight up parole on your ERD or whenever, they can be ready to go out the door, and if we haven't secured a placement for them, even if we have made them Medicaid eligible, there aren't a lot of places that are really enthused about taking our patients.
I understand that. My really specific question was whether Medicaid covers hospice care in the same way that it covers nursing home care.
I don't know the answer to that.
Only from our particular perspective, those that we have taken that have come out of the system into hospice care, we have not been able to get coverage for.
Yeah, I think those are two different questions. One would be the patient's eligibility, and one would be whether the kind of facility they're going to provides care that's Medicaid eligible. So,
well, we provide Medicaid coverage. Yes, we absolutely have. So. On the medical parole question, and Heidi, you're making the distinction obviously accurately between somebody getting a medical parole, which is somebody who's not otherwise eligible for parole but is getting it on medical grounds. And unfortunately, the statute in this state needs to be reenacted in order to allow that. But you've got people, I believe, coming through who actually are either lifers who have long been parole eligible, or like Diane's husband was, or who are past the ERD. Is there any effort on the medical side to work with the parole board and get people who are, preferably before they're actually terminal, but who are seriously ill and obviously posing no risk to anyone, to communicate that to the board and try and get people paroled?
Sure, I would say there's an ongoing effort constantly all the time. I communicate with the parole board. I will personally, and my staff, my social workers, communicate cases, give them information. Can you look at this guy? Here's some information on this guy. So that does happen on a regular basis.
Do you have any idea what percentage of people who are dying in Duane Waters actually were parole eligible at the time that they died?
I don't know. I have no idea.
My experience with that, when Joe first signed up for the hospice program 2 years before he died, they did his medical commutation papers. He died a month before he was eligible for the next 2 years.
I'm sorry, what do you mean he was eligible?
They can only apply for a medical commutation once every 2 years.
Yeah, right.
Joe was a month shy of his 2 years.
But Steve, correct me if I'm wrong, but if once a prisoner enters the Choices program, doesn't automatically that prisoner get recommended for a medical or compassionate release?
Yeah, that's part of the Choices program, is that we almost always, I'm sure there's an exception to our rule somewhere, but we almost always apply for that medical.
But then if they get denied, they're
talking about applying for a commutation, right?
Right. All right. Now, understand, it's not a simple parole, as I understand it. It's actually a governor's...
I understand commutation. I'm trying to understand how many people are in Choices who don't need a commutation, but who actually are parole eligible.
There's two phases in Choices, phase 1 and phase 2, and I'm not an expert, but I don't think that there's a referral for everybody. You can be in phase 1 for years, or a long period of time.
What gets you into phase 1? Just having an illness which eventually, when it runs its course, is likely to be terminal?
Well, I believe it is when you've been diagnosed with a life-limiting condition, you have the option of enrolling in Choices.
But you could be years away from death, is what you're saying?
Sure. I know. I have some guys in C unit that I know are in Choices phase 1.
My next question actually was about C unit, Heidi. You said you have to be at level 1 to be in C unit. What happens to all the prisoners who are above level 1 who need the kind of care that C unit provides? Where do they get if they need...
They're in Duane Waters.
Oh, they're in Duane Waters.
Or Lakeland. Well, Duane Waters.
No, I mean if they need physical therapy, for instance.
Yes, they're in Duane Waters.
So Duane Waters is actually handling people who...
They're in one of the other Jackson facilities, and they come over to Duane Waters for their therapy appointments.
One other person would like to sneak in here. Thanks so much, Mark. Yes, ma'am.
I've been hearing a lot about the compassionate care at Duane Waters, and having been married to a nurse and a sister who was a nurse, I know that nurses are not only trained to save lives, but they have, through their training and experience, an innate ability to sense when a patient is close to death. And I find it just appalling that both of these women were lied to and said that their husbands were fine, when any nurse would know they were not fine. And I find it appalling that any person has to die alone. Why were they not made provision to have the comfort of their wives when they were dying, or even the comfort of a visit within the last few weeks of their life? I find this very unacceptable, and I find it impossible to believe that this would have to happen even once, because any nurse can tell the administrator anything, you need to get the family here because this person is dying now. That's what I wanted to say.
Let me just follow up with, that's really one of the reasons that Humanity for Prisoners got into this whole business of trying to bring hospice care in. It was not only these two ladies, although that certainly had a part of it, but we've been communicating. We're a very unusual prisoner advocacy program because all of our work is one-on-one. We work one-on-one with prisoners. And one of the reasons that we really got involved in trying to bring hospice care into this was working with the women at Huron Valley, which is where all of the women who are incarcerated in Michigan are housed in the 2 units at Huron Valley. And we've dealt with several deaths there that were just really unacceptable. The parole board had denied compassionate release, and these people were certainly not a threat to society anymore. They were dying. They were dying of cancer. And they died in that infirmary, and they died alone. And we know that the families of those women had a really difficult time. I don't know where we're going to go with all that we're seeing and hearing tonight, but I do know the system's got to be improved. We're very close to 9 o'clock. How close are we?
1 minute.
All right. Thank you. Thank you all panelists. We'll wrap it up very briefly afterwards.